Hi, I'm Richard Santucci, one of the senior surgeons at the Crane Center for Transgender Surgery. So this is a quick note on transgender research. We're going to talk about two papers discussing urethral complications after phalloplasty. The first paper is a 2018 review, and it's called Urethral Complications After Transgender Phalloplasty, Strategies to Treat Them and Minimize Their Occurrence. It appears in Clinical Anatomy. To me, this is an important paper personally because it's the first paper I wrote in this field. So one of the promises of coming into this field as a very, very experienced sort of super expert in urethral surgery is that one of my career goals and goals for my patients was to use my knowledge to decrease the amount of strictures, which is a narrowing of the urethra, which is too commonly seen after phalloplasty, and also to use those skills to treat strictures. This, as I mentioned, is personally important because the first thing you need to do when you come into a new scientific realm is to say, well, what do people know about this already? So what I did was read literally every paper ever written on transgender surgery and painstakingly tried to work out what are the stricture rates and what are the things that we could do to decrease those stricture rates. Quickly, by way of conclusion, I'll tell you that there have been some major innovations in the way that the urethra is created in urethral lengthening phalloplasty. And there were some false starts, things that didn't work out so well. And what we use today and what the research seems to indicate is good is a really nice urethra made from the portion of the native urethra. There's something called the pars fixa, which is a stupid Latin term for the urethra between the native urethra and the base of the phallus. That's made by tubularizing some tissue that's in the native female above the urethra and below the clitoris. And if you do that, making really nice flaps so that the flaps have good blood supply, roomy so it's not very small when you first make it, and most importantly, if you put a second layer borrowed from a muscle called the bulbospongiosus muscle, which actually drapes over the top of the vagina. That innovation hugely decreased the amount of strictures and fistulas. And then if you can, the bulbospongiosus muscle only covers over so much, and if you can then borrow some sort of random tissue on each side of that new urethra to make a second layer all the way down, then you have fewer complications. So that was good. This paper became more sophisticated in its next iteration. So together with co-author Min Jun, quick note about Dr. Jun, he'll actually be joining our practice. You know, when you add a phalloplasty surgeon or a transgender surgeon, sometimes you have to hunt these people for years. They don't grow in trees. They have to have the right training. They have to have the right disposition. They have to be excellent surgeons. And so I have been tracking Dr. Jun for many, many years. He finished as a urologist, then he did a fellowship in reconstructive urology, then he did a second fellowship in reconstructive urology, and he's going to be great to have on our team. So this is a 2019 article. It's called Urethral Strictures After Phalloplasty, and this is the sort of big brother of my original effort. And this highlights something that was very important to me, which is what of the things that we've learned about urethral stricture in the cis world. There's 50, 60 good years of research in that field. Can we successfully apply to transgender strictures, and what things don't work as well? And I can give you the quick short answer on that. Some of the techniques used in cis males for strictures do work. Anastomotic urethroplasty, although that's where you just take the bad part out and put the two good ends together. But the problem is that it has a very high failure rate in transgender patients that it doesn't seem to have in cis males. And perhaps a surprise for a lot of us is that there's a two-stage urethroplasty technique called the Johansson urethroplasty. It was published in 1950 by a guy named Bent Johansson, and I imagine that he would be very thrilled, he's obviously long dead, to know that his technique is still one of the preferred techniques today. So the take home from that is that the truth is doing a staged operation, meaning 2 operations to fix a stricture, is quite inconvenient, but the success rate is very high, like 95%. So I think one of the important lessons was that we'd all like to do just one surgery and fix it, but when you do just one surgery and fix it, the failure rate can be quite high, and it could be that surgeon and patient decide to go for the extra time and trouble of 2 surgeries to get a much higher success rate. Thanks.